Welcome to the Deep Dive, the show engineered to shortcut your learning curve. Today, we are taking a massive stack of sources focused on clinical therapeutics and what is probably the single most critical act in modern medicine, good prescribing.
It really is. It sounds so simple, right? Just write a drug name, a dose, a frequency.
Right. Sign your name. Done.
But the complexity hidden just beneath that signature is, well, it's staggering. I mean, the modern prescriber operates under just immense pressure.
And you're navigating so much, the sheer volume of medications out there.
For sure. And the challenges of polypharmacy, especially with our aging demographic, and then there's this constant balancing act.
The tightrope walk.
The tightrope walk between therapeutic benefit and the very real risks of adverse reactions, cost, drug interactions, the list goes on.
And that tightrope, that balance between a good outcome and causing harm, is exactly our mission today. We want to give you the comprehensive foundation, the scientific framework that really dictates how safe and effective decisions are made every single time.
And if you understand the mechanics, you get why the protocols exist.
Exactly.
And that entire framework, it's really built on two core concepts. These two ideas govern every single interaction a drug has with the human body. We call them the two pillars of clinical pharmacology.
Okay.
The first is pharmacodynamics. It basically answers the question, what does the drug do to the body?
And the second pillar, which we'll get to later, is pharmacokinetics.
The reverse question.
Right. What does the body do to the drug? And these two, this duality, they determine everything from how often you take a pill to how quickly a patient actually gets better.
Let's start with pharmacodynamics then. So a drug is essentially, it's a molecular key.
Okay.
And it's designed to fit a very specific molecular lock. Its effectiveness comes from its ability to interact with these targets that are already present in your body.
So it's hijacking an existing system.
It's either hijacking it to stimulate a process or actually more often to block one.
And our source material really hammered home the diversity of these targets.
Yeah.
We're not just talking about one kind of lock. The body uses so many different mechanisms.
Which is why some drugs can work almost instantly and others might take weeks to have any noticeable effect.
So what are the big ones?
The most prominent targets are what we call receptors. And we categorize them based on how they transmit their signal after the drug binds.
Okay.
The fastest acting type is the channel-linked receptor. The drug binds, an ion channel immediately pops open.
Instantaneous.
Think of the GABA receptor. When a drug binds there, it lets chloride ions flood into a neuron, causing rapid suppression. That's the kind of speed you need for, say, an anti-anxiety agent or a quick sedative.
Then you've got the more complex ones, the internal switchboards, the G-protein-coupled receptors, or GPCRs.
And these are probably the most common target for modern drugs. They're just fascinating relay systems.
So they're not a simple on-off switch.
No, not at all. When a drug binds to a GPCR, it doesn't open a channel directly. Instead, it activates an adjacent G protein.
Which then kicks off a whole chain reaction.
Exactly, a cascade of signals. It might activate second messengers like cyclic AMP or modulate other ion channels. It's a crucial system. Beta adrenoceptors, dopamine receptors, they all rely on this G protein cascade.
So that complexity means the response is a bit slower than a channel-linked one, but I imagine it's also more amplified, more nuanced.
Much more. Now, for the really long-term changes, you're looking at kinase-linked receptors and transcription factor receptors.
Okay.
Kinase-linked receptors, like the insulin receptor, they activate intracellular protein kinases when they're bound. That leads to cascades of phosphorylation.
Which is basically like flipping dozens of metabolic switches inside the cell.
Precisely. This usually governs things like growth, differentiation, metabolic control.
And then the slowest of all, the transcription factor receptors. These are the nuclear receptors, right?
Yes. They're generally inside the cell. A steroid or thyroid hormone binds to it, and that whole complex then moves into the nucleus where it either promotes or inhibits the transcription of specific genes.
So it's literally changing the proteins the cell produces.
It is. It takes hours, sometimes days, but the effects are profound and incredibly long-lasting.
And beyond these classic receptors, drugs can target other essential machinery. You mentioned voltage-gated ion channels.
Right, which are critical for any excitable tissue, so nerves and muscle. Sodium and calcium channels are common targets for, say, local anesthetics or some cardiovascular drugs. They just stabilize the electrical state of the cell.
And then you can target enzymes.
Like ACE inhibitors, they block the angiotensin-converting enzyme to lower blood pressure. or aspirin, which blocks cyclooxygenase.
And finally, transporter proteins. This one's really key for understanding a lot of common psychiatric medications.
Absolutely. Transporters are just proteins that move molecules across membranes. So SSRIs, for example, work by blocking the 5-HT reuptake transporter.
Which leaves more serotonin hanging around in the synapse to do its job.
Exactly. And understanding that precise molecular fit, that key in the lock, leads us directly to the concepts of affinity and selectivity.
Affinity seems pretty straightforward. It's just how well the key fits the lock, the propensity to bind.
Right.
But selectivity,
Yeah.
that's where the clinical tightrope really begins.
It is, and it's so often misunderstood. We use the term to describe a drug's preference for one receptor subtype over others, but the critical distinction, the one that prescribers absolutely must internalize, is that selectivity is relative. It is never absolute specificity.
So a drug is only selective at a certain dose.
Precisely. If you raise that dose too high, even a highly selective drug is going to start hitting off-target receptors, and that's where your side effects come from.
The classic example in our sources was about the beta-adrenoceptor.
It's the perfect illustration. So you have subtypes. Beta 1 is primarily in the heart, causing your heart rate to go up, and beta 2 is primarily in the lungs, causing bronchodilation, opening up the airways.
So a beta blocker is designed to be cardioselective, hitting the beta-1 receptors to reduce heart rate for angina.
Right. But because that selectivity is relative, if the dose is too high or if the patient is just particularly sensitive,
It's inevitably going to start hitting those beta-2 receptors in the lung.
and that causes bronchospasm, a disaster for an asthmatic patient. This single fact immediately contraindicates using non-selective beta blockers or even high doses of selective ones in patients with asthma. The molecule is designed for the heart, but that lack of absolute specificity can trigger a life-threatening lung event. That is the clinical reality of relative selectivity.
Let's clarify the actions drugs take once they actually bind. We talk about agonists and antagonists.
So an agonist is the classic action. It binds, it changes the receptor shape, and it initiates a biological response. And we distinguish between full agonists, which can produce the absolute maximum response a cell is capable of.
And partial agonists.
Right. And partial agonists are really important because they activate the receptor, but even if every single binding site is occupied, they can never, ever reach that maximal biological signaling effect.
So a partial agonist might be useful if you want to sort of dial down a system without turning it off completely.
Exactly. And the opposition, of course, is the antagonist.
The blocker.
Purely a blocker. They bind with high affinity, but they produce zero biological response. So you have competitive antagonists, which directly compete with the body's natural ligand for the exact same binding site. And you can usually overcome their effect just by increasing the concentration of that natural ligand.
But the non-competitive antagonists are a different story.
They are much tougher to overcome. They might bind to a totally different site on the receptor, causing what we call an allosteric change that prevents signaling. Or they might even bind irreversibly to the active site.
And once that happens, it doesn't matter how much agonist you throw at it.
Doesn't matter at all. The receptor is just blocked until the body can get around to synthesizing new ones.
So understanding the molecular binding, that's step one. Step two is measuring the actual clinical effect. And that is where the dose-response relationships become so crucial.
Right. If you look at the effect of a drug, either on a population or on a tissue, and you plot the dose logarithmically against the measured response, you typically get this S-shaped or sigmoidal curve.
It starts slow, shoots up, and then plateaus.
Exactly. And this curve is essential for defining two terms that are absolutely critical for prescribers to get right: efficacy and potency.
And these two get confused constantly, even by professionals. So let's really delineate them.
Okay. Efficacy is Emax. It is the measure of the maximum possible response the drug can produce. It's all about the quality and completeness of the therapeutic effect.
So it's the ceiling. How good can this drug possibly be?
That's it. If a drug can only ever fix 50% of the problem, no matter how high the dose, its efficacy is low. Clinically, efficacy is what really matters most.
The example from the source material was perfect here. Loop diuretics like furosemide can induce a far greater total fluid loss than thiazide diuretics.
A much larger therapeutic effect. Therefore, loop diuretics have greater therapeutic efficacy for something like severe edema, even if they aren't the most potent drug.
Which brings us to potency.
Potency, on the other hand, just describes the dose required to achieve a given response. It's defined by the ED50, the dose you need for 50% of the maximal effect.
So if drug A gives the same result as drug B, but at half the dose in milligrams,
Then drug A is twice as potent. Potency dictates how low the dose is, but efficacy dictates how big the result is. And for the patient, a highly efficacious drug is almost always superior, even if it's less potent and comes in a bigger tablet.
Now, if you connect that beneficial response curve to the adverse response curve, that gives you your margin of safety, the therapeutic index, or TI.
The TI is just the ratio of the dose that causes a major adverse effect compared to the dose required for the therapeutic effect. And for the vast majority of drugs, the ones you pick up over the counter, this margin is enormous.
You have to take 10, 50 times the dose to get into real trouble.
Right, but the source flags a small, critical group of drugs where the TI is perilously low, less than 10.
We really need to underscore this list
Yeah.
because this is where the highest risk prescribing happens.
This handful of drugs requires active, often lifelong monitoring of plasma levels. You have digoxin for heart failure, warfarin, the anticoagulant, insulin, phenytoin, an antiepileptic, and opioids.
And with all of these, the concentration you need for benefit is dangerously close to the concentration that causes major toxicity.
It is. Bleeding with warfarin or fatal arrhythmias with digoxin. Every single prescription for these drugs is an immediate red flag that requires incredibly tight control.
The TI curve also helps us clarify the language around adverse effects. You can sort of categorize the risk based on where it falls on that dose range.
Yeah, we distinguish 3 zones. If the dose or concentration rises above the therapeutic range, we see toxic effects.
Okay.
If the adverse effects happen within the intended therapeutic range, ankle edema from vasodilators or dry mouth from antihistamines, those are classic side effects. They're predictable, often manageable.
And then there are the effects that happen below the therapeutic range.
Those are the hypersusceptibility effects. They're often driven by immune reactions or underlying genetic differences. These are the unpredictable, rare events that catch prescribers completely by surprise and have nothing to do with the dose being too high.
Speaking of surprising effects, drugs don't always keep working forever. Let's talk about why the body often fights back, leading to desensitization.
Desensitization is a key physiological response. We have 2 major types. Tachyphylaxis is a very, very rapid loss of response, sometimes happening after just the first few doses.
Why so fast?
It's usually due to a rapid depletion of necessary signaling molecules, like a neurotransmitter that's been released so heavily it just runs out of stock, or a rapid modification of the receptor itself, making it temporarily unresponsive.
And then you have tolerance, which is the more gradual process, right? It develops over days or weeks.
Tolerance is often the result of genuine physiological counterregulation. The body recognizes the drug is disturbing its homeostasis, and it starts processes to negate the effect.
So it's fighting back.
It's fighting back. For instance, if you use a potent vasodilator to lower blood pressure, the body responds by retaining salt and water, which increases blood volume. That physically counteracts the drug's action and reduces its effectiveness over time.
And when the body builds up these counter-regulatory forces, suddenly stopping the drug can be catastrophic.
Yeah.
And that's the definition of rebound withdrawal effects.
Oh, it is extremely dangerous. When you abruptly remove the drug, those counter-regulatory systems that were working overtime to balance the drug, they suddenly dominate the physiology.
The source material gives some very clear warnings here.
It does. If a patient is on long-term glucocorticoids, their entire HPA axis is suppressed. If you stop suddenly, the body can't produce its own essential cortisol. That can lead to a potentially fatal adrenal insufficiency.
And this isn't just about opioids or heavy psychotropic drugs.
No, not at all. Even common medications like SSRIs need to be tapered very slowly to avoid significant discontinuation syndromes. We're talking dizziness, electrical sensations, severe insomnia, anxiety. And then you have benzodiazepines. Abrupt withdrawal can cause severe agitation, paranoia, and incredibly dangerous seizures. The approach here is critical. You stabilize them, often on a long-acting benzodiazepine, and then you start an excruciatingly slow taper. Good prescribing involves the beginning, the middle, and the end of therapy.
Okay, so now we flip the perspective entirely. We've covered what the drug does to the body, pharmacodynamics.
Yeah.
Let's look at what the body does to the drug, pharmacokinetics, or ADME.
Absorption, distribution, metabolism, and excretion. Yes. This is fundamental to calculating a dose. We start with absorption and routes of administration.
And the route you choose dictates not only the speed, but also the bioavailability.
The fraction of the dose that actually makes it to the systemic circulation intact, yes.
And the most common route, oral administration, is basically a pharmacological gauntlet, The drug had to survive the stomach acid, avoid binding to food, get across the intestinal barrier.
And then the biggest hurdle of all, survive the liver.
The first-pass metabolism.
That's the critical step. Once it's absorbed through the gut wall, the blood goes straight into the portal venous system, straight to the liver. And the liver is the body's primary detox center. It's just packed with metabolizing enzymes. If the drug is highly lipid-soluble, the liver's enzymes will chew up a huge portion of it before it ever gets to the general circulation.
And that means, for drugs with a high first-pass effect, bioavailability is low. You might have to give 100 milligrams orally just to get 10 milligrams into the bloodstream.
Which is exactly why, in critical situations, we use parenteral administration. We bypass the digestive tract entirely, and the intravenous route is the gold standard.
Because it's 100% bioavailability instantly. No guesswork.
No guesswork. So when a patient presents with meningococcal meningitis, you don't mess around with an oral dose. You give IV benzylpenicillin for a rapid, guaranteed plasma concentration.
Right.
IM intramuscular and SC subcutaneous are also parenteral. They avoid the first pass effect, but their absorption is slower, less predictable. It depends on local blood flow.
But sometimes we use alternative routes, specifically to bypass that first pass trap, even when the patient can swallow.
For sure. The sublingual route, under the tongue, is a great example.
That allows for rapid absorption through the oral mucosa straight into the systemic veins.
It completely avoids the portal circulation. It's perfect for organic nitrates and acute angina. You get rapid relief. Similarly, rectal administration is used for patients who are vomiting or unconscious, like diazepam for seizures, and it bypasses about half of that first pass effect.
Okay, so once a drug survives absorption, it begins distribution. It leaves the blood and moves into the tissues.
And we use a theoretical concept to quantify this, the apparent volume of distribution, or V dollars.
Well, this is a bit of a strange concept.
It is. It's the hypothetical volume that would be required to hold the entire amount of drug in the body at the concentration we're measuring in the plasma. The calculation is simple. High V dollars equals the total dose given, divided by the plasma concentration at time 0.
Why apparent? Because the number can sometimes be, 500 liters, which is way more water than is in the human body. It makes no physical sense.
It's a mathematical abstraction. It tells a story. If a drug is highly bound to plasma proteins, it stays in the blood. Its concentration in the plasma is high, which results in a low V dollars.
Like warfarin and aspirin?
Right, less than 10 liters. And if they become toxic, you can often use hemodialysis to remove them because they're right there, concentrated in the blood.
But conversely, if a drug is highly lipid-soluble and strongly tissue-bound, it leaves the blood and effectively hides in fat, muscle, and cellular proteins.
So the resulting plasma concentration is very, very low.
Which leads to these huge apparent volumes of distribution.
Huge, sometimes over 500 liters. Digoxin, amitriptyline are high V-dol drugs, and the clinical implication here is crucial. High V-dol drugs are eliminated slowly, they have long half-lives, and critically, they cannot be effectively removed by hemodialysis because so little of the drug is actually in the circulating blood to be filtered out.
So that brings us to elimination. The body's primary goal is to convert these lipid-soluble drugs into water-soluble compounds that can be flushed out. This is metabolism and excretion.
Metabolism is generally split into two phases. Phase 1 is the initial alteration. It's usually oxidation, reduction, or hydrolysis. And the major player here is the cytochrome P450 or CYP450 family of enzymes in the liver. They are responsible for oxidizing the vast majority of lipid-soluble drugs.
And phase I often just prepares the drug for phase 2.
Phase 2 is the conjugation phase. The drug or its phase I metabolite gets linked to an endogenous molecule like glucuronide or sulfate. This process creates an inactive, highly water-soluble conjugate.
And that extreme water solubility is what lets the kidneys excrete it efficiently. It stops it from just diffusing back across the renal tubules.
Exactly.
I think we should briefly touch on prodrugs here because they kind of flip this sequence on its head.
They do. A prodrug is given in an inactive form, and it actually requires metabolism to become active. Codeine is the famous example. It's inactive until the CYP2D6 enzyme converts it into active morphine.
So if a patient is genetically missing that enzyme, the drug just won't work for them.
It will have zero effect.
Regarding excretion, the kidneys handle the vast majority of drugs.
3 things happen there. First, any unbound drug is filtered by the glomeruli. Second, some drugs, like penicillins, are actively secreted into the tubule. And third, and this is critical, lipid-soluble drugs can be reabsorbed back into the blood across the tubule wall.
And that's where urine pH becomes this really unexpected factor.
It's fascinating. Since urine is usually a bit more acidic than plasma, weak bases tend to get trapped in their ionized form and excreted more easily. Conversely, if we alkalinize the urine, say during an aspirin overdose, we can chemically trap the weak acid, salicylate, in its water-soluble form within the tubule, preventing reabsorption and dramatically speeding up its excretion.
We mentioned another recycling system earlier, enterohepatic circulation.
This is a way the body sort of self-sabotages its own elimination efforts. Some drugs are conjugated in the liver, dumped into the bile, secreted into the intestine,
And then reabsorbed back across the gut wall.
often after gut bacteria have cleaved off that conjugate molecule. This process, you see it with digoxin and levothyroxine, can significantly prolong a drug's half-life and its residence time in the body.
This all leads to the final necessary piece of the puzzle: elimination kinetics and dosing. How fast does the drug clear, and what does that tell us about how often to take it?
Most drugs follow first-order kinetics. The rate of elimination is directly proportional to the plasma concentration. You double the concentration, you double the elimination rate. And this is defined by the drug's half-life, or $12, which is constant regardless of the dose.
But the sources warn us about a few exceptions where the elimination machinery just gets totally overwhelmed.
That's zero-order kinetics. Here, the metabolic or elimination system is saturated. It's like a conveyor belt operating at full capacity.
Adding more to the belt doesn't make it move any faster.
Exactly. This happens notoriously with alcohol and phenytoin. And it means that if the administration rate exceeds that fixed maximum elimination rate, the drug accumulates progressively.
And dangerously so.
Oh, very. Zero-order drugs cause toxicity very quickly if the dose isn't meticulously managed, because a small increase in dose results in a disproportionate increase in plasma concentration.
So, assuming we're dealing with a standard first-order drug, how do we figure out the dosing regimen?
The goal is to achieve steady state. That's the point where the amount of drug being administered exactly equals the amount being eliminated over the dosing interval.
And the rule of thumb here is?
It takes approximately 5 half-lives to reach steady state. And that's true whether you're starting a drug or adjusting the dose.
5 half-lives. That timing difference is enormous depending on the drug.
Yeah.
You know, a drug like dobutamine has a half-life of 2 minutes, so steady state is achieved in 10 minutes. It needs a continuous infusion.
But if you start a long-acting drug like digoxin with a half-life of 36 hours, well, it could take over a week and a half to reach steady state.
And if the patient is critically ill, you cannot wait that long to see if the drug is working.
You can't. Which brings us to the loading dose concept. The loading dose is essential for these long half-life drugs. It's a much larger initial dose designed to bypass that 5 half-life weight and rapidly bring the plasma concentration up to the desired steady-state plateau.
And once you've hit that plateau, you switch to the smaller, regular maintenance dose.
Correct. And finally, when you're setting the frequency of that maintenance dose, it's a constant trade-off between patient adherence and minimizing plasma concentration fluctuation.
Right. Fewer doses per day is easier for the patient.
Much better adherence, but it creates these higher peaks and lower troughs in the plasma concentration. For a low therapeutic index drug like levodopa, that fluctuation is dangerous.
So to smooth that out, we rely on modified release formulation.
Exactly. They slow the absorption and maintain the concentration within that narrow therapeutic range. You sacrifice a bit of convenience for a lot of safety.
Okay, so everything we've talked about so far assumes this average patient. But in the real world, drug response varies wildly. Good prescribing is all about predicting and mitigating that individual variation.
And that variation is rooted in so many different patient factors affecting how the body handles the drug.
The most obvious one being age.
For sure. In newborns, metabolism is immature. In the elderly, drug clearance plummets. Renal function typically declines significantly with age. And if you don't adjust the dose of drugs that rely on renal excretion, they accumulate, leading to toxicity. The mantra is start low and go slow in older populations.
And what about sex differences?
Well, women generally have a higher proportion of body fat, which can increase the volume of distribution, the V dollars, and therefore the half-life for lipid-soluble drugs. Then you have to factor in diet, smoking, alcohol.
Right.
Chronic alcohol use and smoking can actually induce or ramp up the synthesis of liver enzymes, which leads to faster metabolism of many other drugs.
The ultimate frontier in predicting this variation is pharmacogenetics, using genetic differences to tailor therapy. This is the whole promise of personalized medicine.
And this field is moving so rapidly from the theoretical to the practical. We have clear examples now where genetic differences dictate whether a drug works or if it's going to cause harm.
like the example of acetylators.
Right. Some people are genetically slow acetylators, meaning they metabolize drugs like isoniazid or hydralazine very slowly. That greatly increases their risk of toxicity and means they need much lower doses.
And coming back to our CYP450 discussion, the genetic differences in the CYP2D6 enzyme are particularly important for codeine.
Yes. As a prodrug, codeine needs CYP2D6 to become active morphine. Poor metabolizers, which can be up to 10% of some populations, will get little to no pain relief from codeine because that conversion is just too slow.
And on the flip side,
You have ultra-fast metabolizers who convert codeine to morphine so rapidly that they're at risk of opioid toxicity even at standard doses. Screening for these differences is quickly becoming standard practice for high-risk drugs.
this genetic knowledge even extends to predicting safety, for example, with statin use.
It does. The SLC01B1 polymorphism is directly linked to an increased risk of severe muscle breakdown or rhabdomyolysis in patients taking certain statins. If we know a patient has this genetic marker, we can preemptively choose a safer statin or a lower dose. This is moving prescribing from guesswork to prediction.
And this detailed science is so essential because, despite our best efforts, we have to talk about the inevitable downside, adverse drug reactions, or ADRs. The source material highlights a really shocking figure. ADRs account for about 7% of emergency hospital admissions.
7%. And the truly frustrating part is that retrospective analysis shows more than half of those ADRs could have been avoided.
So it's preventable harm.
A lot of it is. It often comes down to just failing to assess risk factors. For instance, prescribing an NSAID to a patient with a known history of stomach ulcers or who's already on warfarin, that is a known avoidable path to severe GI bleeding and hospitalization.
To help structure these risks, we use the classic Type A versus Type B classification.
Type A, augmented, are the workhorses of ADRs. They are predictable, common, dose-dependent, and generally related to the known pharmacology of the drug.
So if you give a diuretic, you risk dehydration.
Exactly. It's an augmentation of the intended effect. You usually just need a simple dose adjustment.
But the real danger lies in the Type B bizarre reactions.
These are the unpredictable ones. They're not dose-dependent, they're rare, and they often stem from immunology or genetics. Anaphylaxis from penicillin is the classic example.
And because they're so rare, they often only show up after a drug is licensed and being used by millions.
Exactly. They are the hardest to detect during clinical trials.
To capture the complexity of drug-related harm over time, the source material introduces the more advanced DETEST classification.
Right. This adds the element of time into the equation. So type C chronic reactions only appear after long-term continuous exposure, like developing osteoporosis after years of high-dose glucocorticoids.
And type D, delayed, is the truly insidious one.
Delayed reactions manifest years, sometimes decades, after the initial exposure has stopped. The classic historical example is diethylstilbestrol, DES, causing vaginal cancer in the daughters of women who took the drug during pregnancy. Establishing causality there is exceptionally difficult.
And finally, type E, end of treatment, which takes us right back to our discussion on rebound withdrawal.
These are the harms caused by stopping the medication, not by starting it. Recognizing these 5 categories gives you a much more comprehensive view of patient safety over their entire lifespan.
Since those type B reactions are so rare and hard to catch in trials, we have to rely heavily on pharmacovigilance and safety reporting after the drug is on the market.
Absolutely. Phase 3 trials might only involve a few thousand people. If an ADR happens once in every 10,000 prescriptions, you're not going to detect it reliably until the drug is out there. In the UK, the voluntary yellow card scheme serves as that post-marketing surveillance system.
But the system has a major structural flaw, as our sources point out. The reporting rate is incredibly low.
It's abysmal. Only about 3% of all ADRs get reported, and maybe 10% of serious ones. Plus, because we don't know the total number of prescriptions, the scheme can tell us what side effects are happening, but it can't reliably quantify the actual risk or incidence rate. It's an alarm bell, not a perfect measurement tool.
So if a patient presents with a suspected strange reaction, how does a prescriber methodically decide if it's the drug?
They should use the trend analysis framework. T is for temporal relationship. Did the event happen shortly after starting the drug?
Okay.
R is for re-challenge.
Mm-hmm.
Did it happen again if you gave the drug again? Which is rarely done due to risk. E is for exclusion. Can we rule out other causes? N is for novelty, as has been reported before. And D is for de-challenge. Did the symptoms get better when you stopped the drug? It's the scientific method applied to a patient's history.
Moving beyond single drug risks, Drug interactions are perhaps the leading source of preventable harm, especially with the rise in polypharmacy.
And interactions are most dangerous when the affected drug has a low therapeutic index, our famous list of 5, or if it relies on saturable metabolism. If that metabolism is easily inhibited, a low TI drug can jump into the toxic range very, very quickly.
We classify these interactions again using our two pillars, pharmacodynamic and pharmacokinetic.
Right. PD interactions are changes in effect at the receptor. The effects can be additive mixing alcohol and benzodiazepines causes dangerously increased sedation, or they can be antagonistic, like giving naloxone to rapidly reverse an opioid overdose.
And PK interactions are all about changes in concentration, and this is where the CYP450 enzyme interactions just dominate the landscape.
And the key here is the difference in speed between inhibition and induction. COP enzyme inhibitors, drugs like clarithromycin or even grapefruit juice, they block the existing enzyme function.
So it happens immediately.
It happens immediately and rapidly increases the concentration of co-administered drugs. This is how warfarin's anticoagulant effect can be dramatically and dangerously enhanced almost overnight when a patient is prescribed an antibiotic that inhibits its metabolism.
And the opposite force, CYP enzyme inducers, takes much longer.
Right. Inducers like St. John's wort or rifampicin don't block anything. They stimulate the cell to synthesize new CYP enzymes. That synthesis takes several days, maybe even weeks. But the ultimate result is a long-term reduction in the affected drug's plasma concentration.
Which could lead to a loss of effect.
A total loss of effect. Loss of immunosuppression with cyclosporin, for example, or an oral contraceptive failing.
And finally, there are non-metabolic PK interactions, like those affecting excretion.
Combining ACE inhibitors and NSIs is a classic example. Both drugs can impair the glomerular filtration rate, which reduces the clearance of other drugs like lithium or digoxin, causing them to accumulate and become toxic. Prescribing requires checking the patient's entire drug list, including over-the-counter supplements.
This brings us to the human factor. Medication errors. The data shows this persistent failure rate, with something like 7 to 9% of hospital prescriptions containing an error.
It's high. And most commonly, these are simple failures of continuity and documentation. Omission errors, just failing to document a medication on admission or discharge account for nearly a third of all mistakes. Dosing errors are also highly prevalent.
Especially with high-risk drugs.
Yes, especially around calculating individualized doses.
To improve, we need to understand why the error happened, and we distinguish between slip-slapses and mistakes violations.
Right. Slips and lapses are unintended actions. You meant to do one thing, but you did another, like misreading an illegible chart or transcribing a dose incorrectly. These are primarily fixed by system changes. Electronic prescribing to get rid of illegibility, clear system checks.
Whereas mistakes and violations are intended actions, just based on faulty logic.
A mistake is prescribing a drug with the intention to help, but based on a lack of knowledge prescribing that beta blocker to an asthmatic because the prescriber didn't realize the contraindication. A violation is a deliberate deviation from procedure, like cutting corners when you're rushed. Fixing these requires training, education, and fostering a real safety culture.
The prevention strategies seem clear. We need electronic prescribing systems, but they have to be paired with clinical decision support that flags these things, and absolutely require independent, double-checked calculation for any high-risk dose. The high-risk moments, rushing, working long shifts, prescribing unfamiliar drugs, have to be explicitly mitigated.
The final step in good prescribing is placing the decision within the broader regulatory, economic, and practical context. Let's start with the incredible journey of drug development and cost-effectiveness.
The numbers are just staggering. It can take over 10 years and cost upwards of $2 billion to bring a new molecule to market. And that investment shapes everything that comes next.
Well, the clinical development pathway is mandated by regulators. Phase I trials are small, maybe 20 to 80 healthy volunteers, and they're purely to establish basic safety and PK/PD properties.
Okay.
Phase II involves a few hundred patients. You're looking for proof of concept, optimal dosing, and you often use surrogate endpoints markers that predict success.
And then the critical Phase III trials.
These are large, multi-center trials. Thousands of patients. And you're confirming safety and efficacy using relevant clinical endpoints. Not just a marker, but an actual reduction in death, stroke, or heart attack. Success there leads to market authorization.
We're seeing this massive shift toward biologics, these large molecules like monoclonal antibodies, which present unique economic and manufacturing challenges compared to the traditional small synthetic molecules.
Small molecules are chemically identical and easily replicated. Biologics are produced using living cells. The manufacturing process is incredibly complex, it's variable, it's expensive.
And that complexity means high costs and unique safety concerns.
For sure. Increased immunogenicity, the risk of hypersensitivity reactions.
When a biologic's patent expires, other companies can't make a generic. They have to make a biosimilar.
A biosimilar is a product that is highly similar but not identical to the originator because the manufacturing process itself introduces subtle differences. They require separate regulatory approval, but they offer a crucial chance to reduce the astronomical costs of these targeted therapies.
When analyzing the evidence from those phase 3 trials, prescribers have to look past the often misleading statistics that marketers use. The difference between relative risk reduction, RRR, and absolute risk reduction, ARR, is vital.
RRR makes results sound fantastic. If an event happens 2% of the time in the control group and 1% in the treated group, that sounds like a 50% RRR.
Very impressive.
But the prescriber needs the absolute risk reduction.
What does that actually mean for the patient?
The ARR is only 1%, 2%, minus 1%, and this is the number that matters. It also lets us calculate the number needed to treat, or NNT. You just take 1 divided by the ARR. In that case, the NNT is 100.
So you have to treat 100 people for one single person to benefit from that therapy.
And if the drug is expensive or toxic or inconvenient, treating 99 people unnecessarily to help one might not be ethically or economically justifiable.
And that economic justification is decided by national funding bodies using cost-effectiveness analysis. This is where the price of a drug hits reality.
CEA uses the incremental cost-effectiveness ratio, or ICER,
Yeah.
which calculates the extra cost incurred to achieve one additional quality-adjusted life year, or QAY. A QLA is the measure of the health benefit. 1 year of perfect health is 1 QAY.
This becomes the basis for incredibly difficult, often political decisions. We mentioned the colon cancer example.
Right. If a new cancer drug costs an extra £40,000 to achieve 1 QALY, and the national health threshold for acceptable cost is set at £30,000 per QALY.
That drug will be rejected for public funding.
Exactly. It illustrates that cost-effectiveness analysis places these hard, population-level ethical limits on which medicines can be prescribed, regardless of the drug's technical efficacy.
So, synthesizing all of this, let's look at the rational steps in good prescribing. It starts with concordance.
The therapeutic goal has to be a joint decision. A patient might only care about relieving current pain, while the prescriber's goal is long-term preventative care, like reducing the risk of a future stroke. If those goals don't align, the patient won't adhere, and the prescription will fail. That partnership is non-negotiable.
Once that partnership is established, optimizing the drug choice involves practical considerations, not just scientific ones.
You have to review the patient's comorbidities. Is their liver impaired? Avoid drugs metabolized by the liver. Is their renal function failing? Avoid drugs that need renal excretion.
And beyond safety, adherence is paramount.
Choosing a once-daily ACE inhibitor like lisinopril over a 3 times daily captopril, even if they're equally effective, massively improves the chance of the patient taking it correctly.
Right.
And where possible, generic and biosimilar first. It's just financially responsible prescribing.
We also have to zoom in on special circumstances, these highly vulnerable populations.
Older patients are the most complex group. Polypharmacy, increased sensitivity, reduced organ function. They need lower starting doses, slower titration, and often simpler regimens to manage the dozens of pills they might be taking.
And any drug acting on the central nervous system has to be used with extreme caution.
The older brain is just highly susceptible to sedation and delirium, absolutely.
And prescribing during pregnancy introduces teratogenic risk.
You have to avoid prescribing if at all possible, especially in weeks 2 to 8 of gestation when organogenesis is happening. Pharmacokinetically, the maternal body changes dramatically. Plasma volume, GFR, they all increase, which often results in a lower plasma concentration of the drug. But the risk to the fetus dominates everything. Known teratogens like warfarin, retinoids, certain anticonvulsants, they have to be rigorously avoided.
So the final physical act is writing the prescription, what absolutely must be included for safety.
Detail is everything. The date, patient info, the drug name, formulation, dose, frequency, route, and the prescriber's signature. And for safety, you have to use the generic international non-proprietary name, the INN, to avoid confusion between brand names.
Unless
Unless it's a low TI drug or a modified release formulation where bioavailability between generics might differ. Lithium and phenytoin are the common exceptions.
And we can't stress this enough when it comes to units and abbreviations.
Never use confusing abbreviations like DIG or MCG for micrograms. Dosing errors involving micrograms and milligrams are unfortunately common and can be fatal. You must write micrograms in full.
The process isn't over once the patient leaves. Rational prescribing is a cycle of continuous monitoring.
Right. When the clinical endpoints are years away, like preventing a heart attack, you can't wait. You have to rely on surrogate endpoints or biomarkers that predict long-term success.
So you monitor cholesterol for statins or TSH for levothyroxine.
Exactly. If the surrogate endpoint improves, we assume the clinical outcome will follow.
And when do we resort to therapeutic drug monitoring, TDM, actually measuring the drug concentration in the blood?
TDM is only justified for a very specific subset of drugs. They have to have a low therapeutic index, the clinical effect has to be difficult to observe, and there has to be a predictable relationship between the concentration and the effect.
So our classic TDM drugs are.
Digoxin, phenytoin, and lithium.
And if TDM is required, the timing of the sample is everything. A sample taken at the wrong time is just useless.
It is worse than useless. It's misleading. It absolutely must be taken at the trough concentration, the lowest point, which is just before the next scheduled dose. And furthermore, it must only be taken once the patient has reached steady state after 5 half-lives. Taking a sample during the absorption or distribution phases gives you a concentration that is highly variable and provides zero useful information.
We have completed the journey today, moving from that tiny molecular binding site of a receptor all the way through the body's elimination systems, the ethical calculations of cost, and the complexities of human error.
And I think we've established that good prescribing is inherently an experimental process. Because of all this inter-individual variation, the label is only a guide. The real process requires constant vigilance, continuous monitoring, and the willingness to adjust based on the unique real-time response of the individual patient.
And as we close, let's return to that philosophical tension we explored. We have this incredible hope of pharmacogenomics, truly individualized medicine, tailoring drug selection based on your unique genetic markers to maximize benefit and minimize harm.
But against that hope stands the reality of healthcare funding. We make population-level decisions about which treatments to fund using concepts like ICER and QAYs, which aggregate health benefit and assign a standardized financial value to life extension.
So as prescribing becomes more exquisitely personalized, delivering these highly targeted and often highly expensive gene-based or biologic treatments to a single patient, how will healthcare systems ethically reconcile those astronomical costs with the population-level financial constraints determined by ICER thresholds?
That is the fundamental ethical question that the modern prescriber and health economist will have to wrestle with for the next century. Thank you for taking this deep dive with us. We hope you now have a profound appreciation for the science and the critical safety steps involved in every single prescription written today.
We'll see you next time for another plunge into the knowledge stack.